Hello, my name is Christine Bixby. I'm a neonatologist at the Children's Hospital of Orange County. I'm also a board-certified lactation consultant and the medical director of lactation services at the Children's Hospital of Orange County in Orange, California. Today, we're going to talk about breastfeeding and diabetes, the challenges and the benefits associated with breastfeeding in a diabetic mother. This webinar is considered a resource and does not define the standard of care in California. Attendees are advised to adapt the guidelines and resources based on their local facility's level of care and patient population served, and are also advised to not rely solely on the guidelines presented here. I personally have nothing to disclose. So here's an overview of what we're going to talk about. Why breast milk? And I'll actually be referring to it as human milk, which is becoming the more preferred term, and breastfeeding. And that term also can be referred to as chest feeding, depending on the patient population that you're working with. So we'll talk about why human milk is good for babies and moms and producing it. We'll talk about breastfeeding and diabetes and how breastfeeding helps the general population, how it helps the diabetic mother, and how it helps the infant of the diabetic mother. We'll also go over some of the complications of babies who are born to mothers with diabetes. And then we'll talk about how we support the diabetic mother-infant dyad so they can successfully establish breastfeeding. And finally, we'll look at some breastfeeding and in the setting of diabetic medications or common medications of mothers who have diabetes. So why breastfeed? Why human milk? And so most importantly, human milk is human milk for human babies. It's species specific. It's the milk that's supposed to be going to babies instead of formula, which of course is generally cow's milk based. Human milk is the gold standard for growth, health, and development. When a baby is breastfed or receives human milk, there's a decrease in postnatal infant mortality rate by 21% in the United States. Breastfeeding and human milk feeding promotes mother-infant attachment, which makes sense because the baby's right there with the mom every 2 to 3 hours, feeding and nuzzling and just getting close and loving on each other. There are specific benefits to all moms who choose to breastfeed. One is that we can see an increase in the interval between births, what is referred to as lactational amenorrhea, or that while breastfeeding, it decreases the likelihood, although doesn't guarantee, but does decrease the likelihood of mom becoming pregnant. And we know that interval matters in long-term maternal health. We see more rapid uterine involution, and this is due to when a baby latches onto the breast, there's a surge of oxytocin. And for those of you that work in the labor and delivery setting, that's the human version of Pitocin. And so it gives a natural Pitocin to help contract that uterus down. So it helps get the uterus small. With that, it decreases postpartum bleeding, which is a serious complication that we are very much addressing in our obstetrical side of care these days. Oftentimes we can see women return to their pre-pregnancy weight earlier. I will say this didn't happen to me. I got to keep about 10, 12 pounds while breastfeeding, kind of as the reserve just in case, I guess, and then it went away. So I don't sell that heavily because sometimes it can be a deflating disappointment to mom. And then there is well-documented decreased risk of breast cancer, especially when mom breastfeeds before the age of 30, as well as a decrease in ovarian cancer. Additional benefits to moms are a decreased risk potentially in hip fractures and osteoporosis when they are postmenopausal, so much later benefits. This one is my favorite, especially because I work in the newborn intensive care unit, but we see an increase in mothers' confidence as being mom. And when we're in our setting, in my setting where I work, the lack of being able to be mom because your baby's sick is tiny preemie, but being able to provide milk and saying, I'm the mom, I'm doing something special. And it really does empower moms and help them stand tall as mom. So I think that's an important transition to being mom. In our gestational diabetic population, we do see a decreased risk for later type 2 diabetes. We know moms who have GDM are higher risk for type 2 diabetes, and breastfeeding can mitigate that risk to some extent. And then we see a decrease in other diseases in moms later in life, such as rheumatoid arthritis and cardiovascular disease, including hypertension, hyperlipidemia, which are significant diseases of women later in life. When we look at babies, this is a kind of narrowed down slide, and I would encourage you all to go and look at the AAP Breastfeeding and the Use of Human Milk paper. It's very brief, but there's a wonderful table in there. They're updating this, but I imagine the table will stay even with the update. It goes over about 40 plus benefits of breastfeeding. So sudden infant death goes down by about 20 to 30%, I'm trying to remember. Upper respiratory infections, lower respiratory tract infections, respiratory syncytial virus, which is one of the things that RSV that we see babies get and need hospitalization for. Significant decreased risk in a number of factors that I don't think you can find any other therapeutic that would impact the outcome of so many diseases. So I would encourage you all to go to that table. You can just, it's freely available. Look up the use of human milk from the AAP, and it will, you can review that slide. This slide particularly, and I'll go over this later, looks at the benefits of breastfeeding for obesity, type 1 diabetes, and type 2, but we'll go over that later as we move into the breastfeeding and diabetes aspect of care. When we look at the community impact of breastfeeding, there are significant benefits. There is a decrease in annual healthcare costs in the billions, and that has to do with the fact that human milk decreases the risk for infection in babies, and that makes a huge difference. It decreases mom needing to, if baby's not getting sick, mom can stay at work, dad can stay at work. So we see a decrease in parental employee absenteeism and a decrease in loss of family income for sick kin care, as it were. There's a decreased cost for WIC, our Women and Infants and Children program, although they are now supporting moms with food when they are breastfeeding, so it's not quite as low as it once was. And then there's a decreased environmental burden and energy demands. When you think about the production of formula, you have to take all the components to a factory, make the formula, package the formula, ship the formula out to a store. Somebody has to then pick it up, use the formula, and then create waste. So there is a significant environmental and energy demand when utilizing formula. Now we're going to move on into breastfeeding and diabetes and looking at how diabetes is impacted when a mother chooses to breastfeed. And we'll look at the all-comers, meaning mothers who don't have diabetes in pregnancy or pre-existing diabetes. Then we'll talk about diabetic mothers, those that are type 1 or type 2, the pre-existing or gestational. And then we'll review the infants of diabetic mothers, so what we call IDM babies, and what the benefits are of breastfeeding, common complications of being born to a diabetic mother, and then challenges with lactation. So when we look at all moms, and all moms, those that are not diabetic, what are the benefits of breastfeeding when we look at it through the glass and the mirror of breastfeeding, or of diabetes, excuse me. So for all moms, one can see a decreased risk of obesity by 1% for every 6 months of nursing. And that doesn't sound like a lot, but any percent decrease is going to be helpful. We know that from the CARDIA study, which is the coronary artery risk development in young adults study, women's aged 18 to 30 who did not have diabetes at baseline had a lactation duration that was independently associated with the lower incidence of diabetes later on. So we're seeing benefit in decreasing the risk of diabetes in moms who are not diabetic during pregnancy, but choose to breastfeed, and it decreases their likelihood of developing diabetes later. We see this again specifically in this numerical study by Stubbe, showing a decreased incidence of diabetes by about 14 to 15% for every year that a mother chooses to breastfeed. So inherently, there's great benefit to our non-diabetic mother. So in the diabetic mother, we see a decrease in insulin need. And the theory is that it's due to the sugars in maternal blood being transferred to the production of human milk to meet the glucose needs of the baby. In a study by Riviello, 36% reduction of basal insulin requirement was seen in mothers who were using insulin prior to delivery and chose to breastfeed after. It's unclear in the diabetic mother if there is benefit from breastfeeding in decreasing the likelihood of developing type 2 diabetes later on. So I think that's in the diabetic mother. In the non-diabetic mother, there definitely is benefit, but in the diabetic mother, it's not exactly clear. We do see, and that's in the gestational diabetic mother, we do see weight loss and decreased obesity in mothers who choose to breastfeed, and that caloric demand to produce milk is helping the mother with weight loss and getting back to their pre-pregnancy weight. When we look at insulin requirements, I mentioned briefly that there was that 36% reduction, but what about in our type 1 mothers? And this is a very unique population. They come in and they're type 1 diabetic. Often they have been diabetic for many years before pregnancy, and they have a long-standing insulin requirement. The Stanley group looked at insulin requirements and showed that they were significantly lower than the pre-pregnancy dose that the mom required. During the first week postpartum, when a mother was breastfeeding after having type 1 diabetes during pregnancy, they saw a 54% reduction on the pre-pregnancy dose on day 2 and a 73% reduction on day 3. On day 7, they had returned to their pre-pregnancy requirements, but it is helping managing that stress around delivery, which I think helps moms control their sugars a little bit easier during a very stressful period in their lives. In an additional study, requirements for insulin did not return to normal for up to 6 weeks in some mothers. And this is the Davies paper that you see cited down there from 1989. Some of these papers are old, partly because the data is then hashed out and there's no need to be doing the same study over and over again. A third study found that at 4 months postpartum, some moms with type 1 diabetes who were exclusively breastfeeding had a 13% lower insulin requirement than their pre-pregnancy. So breastfeeding really does impact insulin requirement. This is, I love this slide. This is from CDAPP. It's from their pocket guide for the professional. I don't know if it's been updated since 2013, but it goes over insulin requirements during pregnancy. And as we can see, when moms become pregnant, they start to have a little dip in their insulin requirements, and then the traditional insulin resistance occurs throughout that 3rd trimester of pregnancy that we all are aware of, and many of you all who work in the obstetrical population are helping moms manage this kind of boost in their need for insulin as they approach delivery. And so we see this, as we look at that number 40, that's when we're peaking out at our insulin resistance. We deliver and our insulin requirement goes down significantly. But as you can see, the non-breastfeeding mother is much higher than the breastfeeding mother for insulin requirement. She bounces back up to her pre-pregnancy very quickly, whereas the breastfeeding mother can stay lower for a prolonged period of time, and then will ultimately go back with weaning. I find this a very helpful tool to explain to moms how this will help them if we're not having to manage insulin in a more challenging way, the benefits of breastfeeding for themselves and easing that transition into motherhood, especially for our first-time moms. So for diabetes control and breastfeeding, we know that diabetic mothers, I think you all know, who are working in our lactation or obstetric or pediatric populations with moms who are breastfeeding, that moms who have diabetes often can struggle with breastfeeding. And part of that may be due to their challenges with controlling their diabetes, in that we know that normal insulin levels are necessary for lactation. Appropriate glycemic control increases maternal serum and milk prolactin, which is one of the big hormones of pregnancy, which I'll show you the cycle of making milk in a little bit. But prolactin is very important for the onset of lactation. And so it does show, and we'll talk about this a little bit more, that in moms who have challenges with glycemic control, they have a delay in their milk protection or onset of lactation and that's something we see a lot in diabetic mothers. So here's that cycle of breastfeeding. So we start with the infant nursing at the breast that stimulates the nerve endings in the mother's nipple and areola, sending signals to the mom's hypothalamus and pituitary. The pituitary then releases the two big hormones of breastfeeding, prolactin and oxytocin. And that is making milk and letting down and releasing milk. These hormones then travel from the bloodstream to the mammary gland or the breast and stimulate milk production and milk ejection reflex, or that letdown. And so this cycle needs to go round and round, but if we're struggling with our prolactin levels because we don't have good sugar control, that's going to get in the way of us producing enough milk. And so therefore, it's important to emphasize the value of glucose control to our moms who want to breastfeed, who have diabetes. So what are the challenges that mothers who have diabetes face when they try to breastfeed their babies? We know that moms have a later onset of lactation in type 1 diabetic moms than mothers who are non-diabetic. And this is also seen in type 2. And we will see a greater delay in moms who have poor glucose control. And part of that is that difficulty with the prolactin surge and making milk that way. Type 1 diabetic mothers are also more likely to discontinue nursing at a higher rate during the first week postpartum. And I think that has to do with inappropriate messaging to the mothers, and that we tell everybody the same thing. Keep breastfeeding, your milk volumes will increase. This old concept of the milk coming in, which we don't use that term in lactation anymore, we say coming to volume. That generally everyone says should happen in day 3, maybe day 5. And in a diabetic mother, it may be much later. So I think that we'll talk a little bit more, but messaging matters. We also see that if we have a diabetic mother who gets through the early establishment of lactation and is able to establish a full milk supply, they are able to lactate and breastfeed their babies for the same amount of time as non-diabetic mothers. So it's really about what we do in those first 2 weeks. Can we get that mom up to full volume? Maybe it's 3 weeks for a diabetic mother, but can we get that support to them so that they make it to full volume, and then they can breastfeed successfully for the length of time that they and their baby prefer? In our gestational diabetic mothers that are treated with insulin, we also see a similar delay in onset of lactogenesis too, which is when that milk volume comes up. And that in comparison to our diet-controlled diabetic GDM mothers. So that's an important thing when we're taking care of those moms, is remembering an insulin-dependent mother, whether it's type 1, type 2, or gestational diabetes, is going to be more likely to have a delay in onset of lactogenesis or coming to volume in milk. And we want to make sure that we work with them, give them adequate support, and message appropriately that your milk may come later. And that's okay. Keep pumping, keep nursing. We can do this. In moms with gestational diabetes compared to non-diabetic mothers, we see shorter duration of lactation. And some of that has to do with specific barriers that moms with gestational diabetes have. Some is that they have a difference in breastfeeding knowledge. They maybe are feeling that they can't breastfeed because they have diabetes and their baby has to be taken to the NICU, or they have to give formula because the baby either needs IV glucose or enteral glucose. And then they tend to be pushed to some extent because it's get the sugar in, get the baby's sugar up, be safe, and you're not able to produce it. And so they become less comfortable with breastfeeding. And then they also sometimes miss out on some of that education because the baby's been taken to the nursery or to the NICU to manage the low sugars. So we do want to make sure that we're looking at how do we support them later on to get through this early phase. We get safe, we get a baby with the sugar that's safe, the brain's protected, but then how do we help mom establish that breastfeeding when she's missed out on the 48 hours of hospitalization where we're teaching breastfeeding and she didn't have her baby with her? And as I alluded to, in-hospital breastfeeding experience differ particularly with the GDM mom when compared to a non-diabetic mother, in that they don't breastfeed in the first hour. They are more likely to have supplementation in some fashion. and they don't feed on demand. They're putting the baby on a schedule, and they are more likely to receive a pump and a formula gift pack when the in-hospital experience is studied for our gestational diabetic mothers. So moms, I think our message there is moms should do their best to have the best glycemic control coming into delivery, and then be given appropriate expectations. But we understand that there are challenges for the diabetic mother in making milk. What about the baby who's born to a mother with diabetes? What are the complications? And there are many, but we know there are benefits when moms breastfeed. So this is that slide we showed earlier, and that we see a 24% reduction in obesity for any breastfeeding for a baby. Their type 1 diabetes goes down by 30% if they're breastfed for greater than 3 months, especially if it's exclusive. And then type 2 diabetes, and this is a very powerful, given that this is a disease that is just near epidemic at this point, 40% lower risk, any breastfeeding. So we've got to get these babies breastfeeding. And a mom who's already got either type 2 diabetes or gestational diabetes with an increased risk for type 2 diabetes, we got to get them breastfeeding to help protect the baby from having the same journey as their mother. So breastfeeding decreases obesity and diabetes, and part of how it does that is that there's insulin in breast milk. It is a normal part of breast milk, and it is in there because it promotes gut maturation and reduces intestinal permeability to macromolecules. So it helps the baby tolerate feeds and absorb feeds well. It also, the theory in decreasing type 1 diabetes in particular, is that it may induce an immune exposure early on so that there's tolerance to insulin and we don't develop type 1 diabetes. And so there is great benefit from these studies from Shahade, looking at we may be able to decrease type 1 by just exposing to breast milk early in life. And we talked about this on the slide, that there's 30% for type 1 and 40% for type 2 decrease in diabetes for breastfed babies. And this is one from Dr. Eidelman, who's a great in the breastfeeding world. But the value of colostrum, and that colostrum stabilizes infant blood glucose. And that the theory is that components within that teeny tiny bit of milk, that yellow, what they all call liquid gold, is that it actually components will enhance gluconeogenesis, or the baby's ability to mobilize substrate to make glucose and keep their own blood glucose elevated. So as they transition from that continuous glucose infusion from the placenta to being on their own with periods of fasting, the babies can help themselves by being exposed to colostrum. And this is better than when compared to formula exposure. So we do know that the value of the colostrum, even if we have to give formula or if we have to give glucose gel, we still want to get that colostrum in because it's going to help us stabilize over time. What are our complications to the infant of the diabetic mother? I think the one that everybody thinks of is macrosomia, and that's the baby with the really thick chest. They tend to be a little hairy and they weigh a lot. There are some, though, that are small for gestational age and that they don't have good glycogen stores because the placenta wasn't performing well because of maternal diabetes. Hypoglycemia, as I've already alluded to multiple times, is that the baby is used to a high transplacental glucose infusion that is terminated when they cut the umbilical cord, but the baby's pancreas does not respond immediately, and the plasma insulin levels will remain high so that the glucose is being utilized very quickly and the serum blood glucose goes down, which we know is a risk for the baby's brain, and we want to protect that by keeping glucose in a normal level. Low calcium and low magnesium can happen, and that can even result in jittery movements that people attribute to low glucose, but it's actually due to calcium levels instead. So we want to be looking at all of that if we have a diabetic baby who's behaving abnormally. Respiratory distress syndrome, or what we would call premature lung disease with surfactant deficiency. For same gestational age, we tend to see more immature fetal lung development. So a baby that I would expect that's non-diabetic to be breathing fine, I would expect that potentially a diabetic baby would be more likely to behave more immature and need help for their lungs like they were a preemie baby. TTN, or transient tachypnea of the newborn, or retained fetal lung fluid, is often seen because babies have C-sections, because they're large and there's concern about shoulder dystocia. Hypertrophic cardiomyopathy, or septal hypertrophy within the heart, which is where we get a thickening of the wall between the two ventricles that then gets in the way of the outflow tracts. And this is due to insulin-like growth factor and the insulin facilitating laydown of extra tissue in that septum in response to these high insulin levels. Diabetic babies classically have poor feeding. They have a discordant suck and swallow and a lack of endurance that is not related to their prematurity or their history of need for respiratory support. These are the babies that we just can't get them to feed, and we don't know why. And it takes a long time, and oftentimes on some babies, they do need a gastrostomy tube to get home. Other complications include hyperbilirubinemia, or an elevated jaundice, and that is oftentimes due to polycythemia or a high hemoglobin. As they're dealing with a placenta, they may not be functioning well, and they're carrying a higher red blood cell load or high hemoglobin in order to extract as much oxygen from the placenta. And then there's clotting issues, renal venous thrombosis, which may be due to that polycythemia or hyperviscosity, low blood pressure, or DIC. Other complications, a lot of these are more related to poor control in the very early stages of pregnancy. So we can see heart disease such as transposition of the great arteries, ventricular septal defect or VSDs, atrial septal defects, ASDs, renal agenesis, small left colon or situs inversus where the bowel is on the wrong side, anencephaly and myelomeningocele or meningoceles, skeletal defects, including caudal regression syndrome, which is where we just don't have appropriate development of the lower portion, including sometimes the legs are fused. This is often associated with very poor control early in the 8 to 10 weeks, oftentimes when moms don't even know they're pregnant. Microphthalmos and unusual faces. So the diabetic baby's got a lot of challenges, although with good glucose control, a lot of those complications can go away with, and we know there's benefit to breastfeeding now to the baby who's exposed to a mother with diabetes, as well as to the mother with diabetes. But we know there's challenges. The baby who's hypoglycemic is going to be taken away and given glucose gel or given formula or put on an IV because their sugar control is so challenging. And that's going to get in the way of our appropriate development of a breastfeeding diet. So how do we help them? How do we help a mom who's diabetic, who has the challenges of managing her own diabetes, and then a baby who has complications of diabetes? How do we help them successfully establish breastfeeding? And some of these are the things that help everybody establish breastfeeding, which is educating people. When we look at our diabetic mothers, we're going to educate them not just on the benefits of breast milk, which we should do for all, and that we want to do early breastfeeding, skin to skin, all of the things that we do for all of our moms, but we need to focus on some of the other components that are very specific and unique to our diabetic mother-infant diet. One is prenatal education. We know prenatal education makes a difference in maternal decision to breastfeed, likelihood of successful breastfeeding. So what's said in the obstetrical office matters for all mothers. In our diabetic mothers, we want to add in how important glucose control is, especially as we approach delivery, and that it's going to help manage the baby and make it easier to keep the baby together with mom so that they can do some of the basics of breastfeeding, skin to skin, early latching, demand feeding. We want to have them optimize that blood glucose control prenatally, and particularly in the days and hours prior to delivery. The likelihood of a baby needing to be in the NICU for glucose management is directly associated with maternal glucose at the time of admission to labor and delivery or immediately prior to delivery. So we really want them to focus, yes, on glucose control throughout, but particularly in those latter parts of pregnancy, which is really hard to control, like we showed those insulin requirements going up, but that is a priority. And then there's this concept of pumping prior to delivery, which got a lot of people really nervous because pumping means we're going to result in an increase in oxytocin or Pitocin, which is a common medication that we use to induce labor. And so there was a study called the Diabetes and Antenatal Milk Expressing Study, or the DAME study. And I'll go over that one in detail. Other issues that we can do are minimize separation. Use hand expression to get the colostrum out, spoon feed the baby with the colostrum, optimize colostrum so we can see that supporting and balancing out of gluconeogenesis. Using glucose gel. I'm not going to go heavily into it, but glucose gel protocols I think have become standard of care, or at least finding their way into most hospitals now. And then how do we support a baby? Do we use formula or do we use banked breast milk? And that's a difficult and complicated conversation. In that formula means I can give you formula and I know when you go home you can get it. Banked breast milk, I can give it to you in the hospital. I can't necessarily get it for you at home. You're going to have to pay for it yourself if you want to. What's the best solution? And I think most times we do some banked breast milk to message we want to see if your milk volume will come up. Standard term birth hospitalizations don't end up staying long enough where we can see milk volumes established to an adequate volume. So oftentimes we do have to transition to formula for a bridge. And I think that's the important thing, is messaging that the formula use is not a long-term plan and that it's a bridge until milk volume comes. And that messaging is very important for moms so they don't feel deflated and that they have failed in breastfeeding because we're giving formula. And that messaging of it's a bridge, we know your milk will come, just keep going, and this is going to keep us safe until your milk volumes come, is helpful in setting them up for that success later on in breastfeeding. So let me just go through the DAME study. It's a multi-center 6-hospital study, unblinded, randomized controlled trial. Women with pre-existing or gestational diabetes with a singleton pregnancy at 34 to 37 weeks gestational age were recruited. They were randomized to standard, come to the hospital, have a baby, we'll see what happens, and do normal, ideally breastfeeding supportive care. And then doing, the other group was randomized to doing hand expression 2 times a day. So just doing some hand expression to start making milk, to collect some milk, as well as to get the breast ready to go. The primary outcome was proportion of infants admitted to the NICU. So this was a safety trial and not looking at, they did look at some of the other secondary outcomes, but it was really to look at, is this a safe thing to be doing? Are we causing preterm delivery? Because there was a lot of discomfort with hand expression prior to delivery. And what they showed was that out of a study of 635 women, and about split between the intervention and standard care, the same number of babies were admitted to the NICU, 15 to 14%, so no significant there. There were no significant adverse events. In the intervention group, only less than 1% needed to go to the NICU for respiratory symptoms, so they may have been going for glucose control issues. And in the control group, there was a less than 1% moderate or severe encephalopathy. So those were the only 2 identified adverse events, but they were a very small number. The conclusion of the DAME study was there was no harm in advising women at low risk to express starting at 36 weeks. And this is just twice a day with hand expression. But that way the mom was coming in with some milk and the breasts were kind of primed to start making milk once the baby was born. So the decision to support prenatal hand expression, and I will say certain populations are more prone to doing it than others. A very committed mother we do talk about it, and I do see them coming in with breast milk ready to go. Others are a little more shy, but I think it's an option that's worth considering and exploring in a very committed mother. So how do we support them? Lactation support. And we want to support them and help them set up a successful breastfeeding and extracting of milk. So if baby needs to be supplemented, and this is for all moms, but particularly with our diabetic mothers, because they often need supplementation for safe glucose, even if latch is good and we're expecting that breastfeeding will be successful. If the baby is receiving any formula or banked breast milk, mom needs to be pumping at that time. And that's so that the brain and the breast are getting the signal of, you got to make more milk because the baby's taking more. Inherently, when we feed a baby 15, 20, 30 mLs because their sugar's low, we just defined an inappropriate expectation of the breast. Now the breast is not going to be performing like the bottle because the breast doesn't have that much milk at this time. And so we do have to use that formula as a bridge, but we've got to tell the breast, make more milk, this baby's going to need more. So we see production start to match need for the baby. If there are any complications with direct breastfeeding, mom's got to be pumping, and very religiously, in that she's meticulously pumping every 2 to 3 hours. Defining expectations, and this is important prenatally as well as in the peripartum period, and that with diabetes, you may see a delay. That 2, 3, 5 day, your milk volumes will come in or increase. That may not be happening, and it may not happen until day 7 or day 10. And so when I meet any of my diabetic mothers, especially in the NICU, when they've met me and we're in this challenging environment of your baby's needing an IV, and we can't necessarily get consistent breastfeeding because we're needing to get sugar safe and get off the IV, we want to be able to tell them, keep going, keep pumping. Yeah, I know you're only getting drops. That's okay. Keep going. It's going to come. It'll come. It'll come. And so really defining the expectation of 7 to 10 days is very helpful, because if everybody's telling you day 3 to day 5 and you hit day 5 and you have drops, you're likely to say, this isn't working, I'm done. And if somebody says, hey, you might have a delay because of your diabetes, keep on going, and day 6, you start getting a little bit more than a drop and you get a ½ ounce, and day 7, you're getting an ounce, and by day 10, you're getting an ounce and a half. That's going to be helpful if you would define that as an expectation rather than them feeling like a failure because they're not meeting a non-diabetic mother's expectation. And then this concept of educating on the role of supplementation. What is the role of supplementation? We're not giving formula because we don't think you can make milk. We're not giving formula because we don't think your breastfeeding is going to be an option for you. We're giving formula because we need to use it as a bridge until your breasts are able to make enough milk, the baby is able to latch, or we figure out whether latch plus bottle is going to be the appropriate feeding method for your baby. But it is a bridge, and the plan long term is to have the formula go away. And that's important for moms, because if you just say we're giving formula, to them that means I failed. And if we say I'm giving formula as a bridge because we know your milk's going to come, that's very helpful. If you do supplement, the choice to supplement with, it depends on where you are and what part of the hospitalization. If we're in and it's a vag delivery and mom's going to be home in 24 hours, using bank breast milk, although makes us feel better, doesn't set us up with a successful transition to home. And we know milk's not going to be full volume in the mom, so we may need to use the formula instead of banked breast milk. Important to always pump if supplementing. And then having a plan, either with the pediatrician or with your mother baby assessment center or whoever follows your mom's post-delivery, on how we are going to discontinue that formula after we go home. And that we've got you safe, we give a little formula, we do some breastfeeding, you do some pumping, you're good to go home, the baby's sugars are safe, but then we send them out with no plan. So it is important to say, okay, follow up with your pediatrician, and in time, breastfeed first, and as the things go forward, that formula will fall away. But someone needs to be monitoring that to make sure that they're staying safe with safe sugars for the baby. And I'm not advocating for glucose monitoring for babies at home. It's more looking at maternal milk supply than anything. We're going to transition to medications and breastfeeding, because we know that a lot of our diabetic mothers have other comorbid diseases or illnesses that require medications. Oftentimes, they are managing high blood pressure. They're managing high cholesterol. Some of them have depression, among other medications. And so, again, it's important to note that the approach oftentimes by our providers is to provide, just to say it's safer to not breastfeed. And really the answer should be, let's figure out the safest method to treat your disease and continue breastfeeding. We know that over 90% of medications are safe in breastfeeding, or there's another alternative that is safe. It's very uncommon. I mean, a chemotherapeutic is something that we can't have while breastfeeding, obviously. It's important to look at, when we talk about medications in breastfeeding, how do medications or drugs get into the human milk? And it's important to note certain medications are more likely to get into milk. So highly fat-soluble compounds will get into breast milk. Those that reach very high concentrations in the maternal circulating plasma and blood are more likely to have a high to low concentration gradient that would push that component into the milk. and a small molecule, and a molecule that's not bound to protein, because binding to protein makes you a big molecule even if you aren't. So the other thing that is often referred to is the relative infant dose, or the RID, when we start looking at medications. And we're always looking for something that's less than 10% of the maternal dose, and that is deemed usually safe most of the time. So this is one rating scale. It's the one that I utilize, but there are others. This is Thomas Hale, who's a pharmacologist, and his life work is looking at human milk and medications. I'm sure you've all seen L1 through L5. L1 is something that we have, an L is a safe and compatible, and we probably have some data or a lot of experience, or the baby can't absorb it. That's an important component. If you can't absorb it through your gut and it must be given IV, then it's a neutral event to the baby, even if it's in the milk. L2 is considered safer. It's one that we often give without any concern. And L3s we often give as well. L4 and L5 is when we have notable risk to the baby, or L5 where we know there's significant risk or the baby will be damaged and we don't use it. So that's your chemotherapeutics or stimulants, etc. L3, some of the medications do require monitoring depending on what adverse side effect there is associated with it. So I'm going to run through some of the common medications, and this is here more just to kind of pop through them. There are more and more medications coming, so every hospital has access to some way of assessing safety in human milk. At the Children's Hospital of Orange County, we have access to Dr. Hale's website and his program that allows you to just type in the medication and it comes up. There are a number of other resources. There's elactancia.org, which is one of my favorites because it gives handouts in Spanish. You look it up in English and then you click the Spanish button and it will give you a handout that you can hand to the family so they can read it in Spanish, which is very helpful, especially being in California. For specific medications, we'll run through them. Insulin is an L1, which we all know we give it in pregnancy and we give it to babies, we give it to moms, and so we can continue to give that and it's safe in breastfeeding. Metformin, which is one of your more common type 2 diabetic or GDM medications, is also an L1. We have safety that's known. It doesn't get into the milk very much and it's undetectable in the baby's blood. And these babies have normal outcomes. Some of our other medications, glipiride's in L2, similar low levels in the serum, and it doesn't affect infant glucose. Same thing for glipizide or glucotrol, so all our sulfonylureas. When we look at repaglinide, which again, bear with me, I'm not in the adult world, so I don't say these medications correctly, and Prandin, it's an L3, and this one does require monitoring to make sure that the baby's sugars are safe. And then this is one of those things that we can do to mitigate risk is we breastfeed well after the dose to reduce exposure. So oftentimes we would take the medication right when we're breastfeeding so that we know it's not, or even 15 minutes before, to maximize the time interval since it still hasn't been absorbed, and then we get it into, then we can breastfeed, 3 hours later. Rosiglitazone or Avandia, L3. There isn't data though, but the thinking is that the relative infant dose is too low to be clinically relevant. Some other diabetic medications, Januvia, the acarbose or Precose are L3s as well. Invokana, that one, the data is still evolving. When we made these slides, it was still in L4, so there was concern about it. So kind of shying away from those when you have so many other tried and true, reliable old friends to help us. When we look at other medications that moms are taking, some of these are all mothers, obviously pain control for post C-section. Percocet is an L3 and it's felt to be safe. The acetaminophen's an L1, the oxycodone is an L3. It may concentrate in milk, so that's an important, she needs to be expressing regularly. And you can have sedation at higher doses, so avoiding over 40 milligrams per day, the oxycodone. The other thing that's important is Percocet should only be a short-term medication. So and mom shouldn't be using excessive dosing. So it's Percocet is safe in brief use without repetitive frequent dosing. So the hope is that it's only 1 or 2 a day and that she's off by, generally in the NICU, if mom's still on it by day 9, I refer them back to their obstetrician to figure out what's going on and see if we can find a better option that may not lead to a sleepy baby. Ibuprofen, of course, is an L1. This is our favorite analgesic in breastfeeding mothers. It gets very little into the breast milk, and we give it to babies, and we give it to preemies to close their PDAs as well. Antihypertensives, because oftentimes, especially type 2 diabetes, co-travels with hypertension. So methyl-dopa or Aldomet, which is a beloved medication of our obstetric partners, is L2, very low dose into the milk. And this is our preferred antihypertensive, which is, for those of you in the obstetric population, see this medication a lot. Propranolol or Inderal is a preferred beta blocker if you need it. We do use this medication in babies, although we do, when we're giving it directly to them at therapeutic levels, we have to follow them for low glucose as well as bradycardia. But the milk transfer is quite low, so it is felt to be okay. With long-term exposure, the baby should be followed. Labetalol or Trandate is L2 with very extremely low milk levels, so pretty safe medication as well. Diuretics, which I'm a neonatologist. We like diuretics for chronic lung disease in babies, but I'm not a fan of diuretics, but particularly in our pregnant or lactating population. In the lactating population, it will potentially decrease milk supply. So it should be targeted, it should be low frequency, and if we can stay off of it, that would be preferred because it is going to get in the way of our hormonal axis and producing adequate milk. So Lasix, low oral bioavailability, so it's felt to be safe, so it's minimal risk. Hydrochlorothiazide is an L2, again, very low crossing over into the milk. Aldactone or spironolactone is an L2 with a low relative infant dose. And part of why I don't have RIDs is not every medication has been studied. And then it is the serum levels are too low to be clinically significant. When we look at cholesterol lowering agents, I don't think the work has been done to look into it because the thinking is that atherosclerosis is a chronic disease and it makes more sense to just not utilize lipid lowering agents during pregnancy and lactation to protect the baby because it's not going to have a significant impact on primary hypercholesterolemia and the long-term outcome. So cholesterol and products of cholesterol biosynthesis are very essential components for fetal and neonatal development, particularly brain development, and the use of cholesterol-lowering agents would be concerning under those circumstances. So they're not going to be studied. You're not going to get an L because it's not something we really want to be using. So if you get an L, it's a guess, probably saying L4 or L5, just because we don't think it makes sense when we're trying to grow a brain, we're trying to lay down fat. We don't want cholesterol being lowered in that setting. Antidepressants often co-travel as well. So Celexa is L2. Babies can sometimes be sleepy or irritable. Lexapro is the preferred over Celexa, and the milk levels are low. Paxil, which I think is being kind of phasing out significantly, is an L2. And I don't have Zoloft in here, which is one that is very much preferred these days. So I think that data is always a moving target. So looking at an updated and new reference, I wouldn't utilize these slides to look up the L. I would go to the primary source like a Hale or Lactantia or one of the other breastfeeding and medications references that are available. Galactagogues, medications that are used to help milk. Metoclopramide or Reglan helps increase prolactin levels. In lactating women, it can cause some sedation and depression in mothers, and then it's a black box with tardive dyskinesia after significant exposure. So this is a medication that is utilized under the guidance of an obstetrician to help moms make milk. It's not something I generally recommend. It's more important that we do the right thing in the beginning, and that is get them pumping within 2 to 6 hours after delivery, or hand expressing or nursing, and then regular frequent pumping with an appropriate pump. I didn't mention that, but it's very important that if we're sending a mom home who's needing to pump, we've got to make sure she has an adequate pump. Domperidone, which is not currently legal in the United States, but has large experience in breastfeeding mothers. It's a peripheral dopamine antagonist. It increases serum prolactin and stimulates milk production. This drug is more so in the less than 32-week population and not so much in the term population. And then herbal medications are not FDA regulated, so I do not recommend them. The one thing I do recommend is a galactagogue when asked with my lactation medical director hat is oatmeal. Oatmeals are wonderful. It's good for everybody. It's good for your heart. It's good for your cholesterol, and it's also good for making milk. It is a galactagogue, and it's safe, and so everybody should be just eating tons of oatmeal when they're trying to breastfeed. So I think just to finish up, diabetes can get in the way of breastfeeding. It has significant benefits for babies and for mothers. And if we do the right thing, define expectation of 7 to 10 days for milk volume. Safe formula or supplementation with bank breast milk is a bridge to milk. We're going to get you set up with a pump and appropriately latching or with a good feeding plan, even when you go home, and a plan to transition off your formula. These moms have the potential, and these babies have the potential to be a very successful breastfeeding dyad. We just have to do the right thing and support them appropriately. And this concludes the CDAPP webinar.